Welcome to Trial Site News Podcast Series. We are excited to have Dr. Brumley here with us today from Aspire Integrative Medicine. Her clinic is all about combining healing with proven treatments to provide their patients with the best in holistic care. Today we will be discussing the possible ramifications of H.R. 1959, a bill that is titled as Preserving Patient Access to Compound Medications Act of 2019. So Dr. Brumley, welcome.
Thanks so much.
Now, before we deep dive into the topic of the day, if you would, tell us a little bit about your practice.
I am a naturopathic physician. I'm practicing in Utah, and so in the state of Utah, I'm licensed as a primary care physician, and I have a pretty wide scope of practice. Now, throughout the country, it differs from state to state. But here in Utah, I can prescribe medications, and what we're going to be talking about today, particularly compounded medications. And so I'm really general practice. I treat pediatrics, through the adult lifespan to the elderly, and for all sorts of conditions. My practice is mainly focused on chronic diseases. That's where I find that naturopathic medicine really excels in people who have chronic infections such as Lyme and Epstein-Barr, patients who have cancer and maybe going through traditional routes of cancer care. But there are a lot of things that in naturopathic medicine we can do to support that process so that it works better. And then I see people with colds and sore throats. So it's a wide range of things that I do.
Gotcha. So you kind of cover it all.
Mm-hmm.
Well, that's impressive. Out of curiosity, you said the holistic elements for cancer. Could you expand on that? I'm all kinds of curious.
Well, in my training, our focus is really on physiology, how the body works, the biochemistry of the cells, and the cofactors that are used in those processes, which are vitamins, minerals, and sometimes plant extracts that have a lot of healing properties because they make our bodies work better. So one of the things that I think we'll get to today is doing IV therapy with vitamin C. Now, it's very useful in cancer care. And there have been not numerous studies, but definitely some studies that have shown that if you use these vitamin C as an IV infusion and you're using high doses, it actually has an oxidative effect rather than an antioxidant effect, which is what we usually think of when we think of vitamin C.
Right.
Now we compare that to chemotherapy, which is an oxidative process. As you do the oxidation, you are killing cells. So the high dose vitamin C in an IV does that and can actually work in conjunction with chemotherapy to make the chemotherapy work better.
Wow.
So there are numerous other things that we'll do, but that's one example.
Well, very cool. I'm going to definitely follow up with you later on that. Now, before we get into the details of what these changes to the bill H.R. 1959 possibly means, let's first discuss what is compound medications and why the compound medications are important and why and who they work for and why you want to fight to protect them or to protect offering them.
Yes. So there are a lot of different practitioners that use compounded medications, not just naturopathic physicians like myself, but medical doctors, DOs, PAs, NPs, all of these acronyms. But there's a wide range of practitioners who are able to prescribe that would choose compounded medications for patients who are particularly sensitive. Maybe they're sensitive to a dose. Maybe the drug is made in a 100 milligram, but they don't feel good on the 100 milligram and they would like a 50 milligram. But there's not a drug manufacturer that makes that. So you could send that prescription to a compounding pharmacy and say, will you please make up a 50 milligram of this dose? And then your patient tolerates the 50 milligrams. Now, in some cases, maybe you can cut the tablet in half or fourths or, so you try and work other ways if you can't get it compounded. But the other aspect of that is that oftentimes as you have a drug and it's full of binders and fillers. Maybe it's got gluten in it or dairy, and somebody has celiac or a dairy allergy, gluten allergy, and they can't take that medication. Mm-hmm. You can send the prescription to a compounding pharmacy, and they will make it with something else. They'll make that drug in whatever dose you specify, but they'll fill it with a little rice flour or something, very hypoallergenic and benign that the patient then can tolerate to take that drug.
I see.
And then there are some cases where you use a drug off label, and if you're using it off label, you can get it compounded in a dose that would be, and you could pick any dose. The thing that probably your listeners would be most aware of as compounded medication are the bioidentical hormones. You can't get them through a drug manufacturer, except for, well, that's not entirely true. You have just certain doses of estrogen, progesterone, and testosterone. So if you want any other dose besides what's actually made by a drug manufacturer, then you would go to a compounding pharmacy. Compounding pharmacies can take a drug, say the drug company makes it in a tablet, and your patient can't swallow a tablet. Say you have a pediatric patient, can't swallow pills, needs it in a liquid. You would send that to a compounding pharmacy. They would make that drug into a liquid or a troche that you dissolve under your tongue or a cream that you put on your skin. So it gives us a lot of alternative dosing strategies, ways to keep any allergens that might be in those binders and fillers, keep those out of it so that doesn't become an issue for a patient, or that the route of administration can be really just about anything you want. Eye drops, topical, sublingual. So it just widens the variety and gives patients a lot more options for ways to take medications that are going to help them to heal or manage their condition.
Right. So why do you think the USP, the FDA, and other groups, along with elected officials, are trying to remove compound medication as an option?
Well, the main thing is they want to set these strict guidelines for what pharmacies can and can't use to make up a medication. And it's not so much that they're trying to remove all the compounding. I mean, there will still be compounding, but they're really just defining what can and can't be used in those compounds. So, I mean, they asked certain groups. The IMC is one of them, the Integrative Medicine Consortium. The AANP, which is my organization, our naturopathic, it's called the American Association of Naturopathic Physicians that I belong to, they're part of that. And so they asked these groups of people, what compounds do you particularly use and would like to see used in compounds? So they sent in a list of nearly 500 things. I mean, some of them are essential oils, some of them are herbs, some of them are vitamins and minerals, some of them are drugs. So they sent in this list to the USP and the FDA, and then those groups went through that list of about 500 additives and decided which ones they wanted to look at and which ones they don't. And so they put those in categories. They've got categories 1, 2, and 3. So the category 1s were a list of maybe 40 that out of the nearly 500 that they said, okay, we're going to have hearings on these, look at their safety profile and decide which ones we're going to keep in the bill and allow for use and which ones we're not. And so as they've gone through those, they actually, so as they were looking, let's say they were looking at actually at this point 200. And so far to date, they have approved 16. and they only have 20 more to go. And then they had, category 2, they just immediately made illegal. And that's a very short list. And then category 3, which is nearly, category 3, I think is nearly like 250, 300 substances. They just said, no, we're just not even going to have hearings on these, and we're not going to allow you to use them.
Wow.
So they've, we're stuck. We've got 16 out of the nearly 500 that we were using. And now with the option of only having a potential 20 more to go, if they were to say yes to all of those.
Huh. Now, for our listeners who may not know, explain who the USP is and what it stands for.
Well, the USP stands for the United States Pharmacopoeia, and they set the standards for all the drugs that we use in this country. They do the testing and the assays to determine the strength, the quality, and the purity of a drug. And so then in doing that, they make up something called a monograph. And a monograph is a very specific, detailed written study of a single specialized subject. So in this case, it would be a drug or an herb or a vitamin, something like that. So they have these monographs, and that's really their job, is to make sure that we know what the drug is, what it does, are the drug manufacturers making a quality and pure product, and so they govern that and they work in conjunction with the FDA.
Right. So what are the possible ramifications for removing most of your options for compounded medication?
Well, a lot of it is really just that detrimental effect for patients who don't do well on conventional medications, who need a liquid instead of a tablet, who are allergic to gluten but can't get it unless it's compounded, and then the other part that I haven't brought up about that too is the use that we do for IV therapy, injection therapy, which many of the things that we use historically have been compounded. I'll bring up an example here. Is that the USP has a monograph on cyanocobalamin, which is what people usually think of as B12. Okay. If you go into your doctor's office and you're low in B12 and they say, oh, I think we should do some B12 injections. More often than not, in a conventional medical setting, they're going to give you 1,000 micrograms of cyanocobalamin. So it's FDA approved. It's got a monograph through the USP. There's another B12 called hydroxocobalamin. That hydroxo bound to that B12 makes it more useful for people who have diseases with their mitochondria. And that's a whole other can of worms in the medical field. But the mitochondria are what make your ATP. So usually if people have mitochondrial issues, they're tired. Their muscles are weak. And so doing a hydroxocobalamin is a better choice than cyanocobalamin. Right. And if you have it compounded, you can get any strength. It could be 1,000 micrograms, it could be 5,000 micrograms, it could be 10,000 micrograms, even though that's a really high dose. People aren't going to be using that. But you'd have the option to do as much as it takes. That hydroxocobalamin has a monograph through the USP and is FDA approved. So the third type of B12 that we actually is on the list to go into the hearing on through this HR 1959 bill is methylcobalamin. So it's a B12 that's bound to a methyl group. It has some great safety research done on it. It is very useful, most particularly in children and people with autism. You do a little sub-Q methyl B12 injection, so it's just right under the skin. It doesn't go into the muscle. But the research on that is showing that you give this methylcobalamin to these children with autism, and I can't say across the board it's going to help everybody, but it has shown to be very, very helpful in increasing those activities of daily living where they can pay attention more to their schooling or have better concentration or not have so many, kids often will have tics and things like that. Mm-hmm. So you see improvement in those with the methylcobalamin, but there is not a monograph through the USP as of yet, and it's not FDA approved. So right now I'm still using it, but there's the potential that if through the hearings they decline that, we won't be able to get methylcobalamin in an injectable form. You can still get it through a supplement, because what we're talking about does not affect supplement companies at all. So you can still get a sublingual methylcobalamin, but it has not been shown in the research to provide the same benefit as that little subcutaneous injection of that same substance of methylcobalamin.
Gotcha.
So it can be a big deal for a lot of people.
Right. Now, part of the argument that people did receive was that people received contaminated steroid injections from a compounding center. Now, was this contaminated steroid a compound, and does this directly relate to compounded medication?
So this is really where it all started, that the FDA said, okay, we need to nail down and take better control of what's going on in these compounded pharmacies. So in September of 2012, there was one single compounding pharmacy. They made a batch of compounded cortisone. Now, this is the cortisone that people they have knee pain. They go to their doctor, they get an injection in the joint, and I see 50-50, 50% of the time, they feel better. It takes away the inflammation. So it's not anything that has been particular to naturopathic medicine, but more orthopedic specialists and maybe some primary care who are injecting these joints with this anti-inflammatory. But this pharmacy was compounding it, did not take the proper precautions, and it was contaminated. So at this time, and to date, what we know about that is that, at least 800 people became really sick from it. And I believe it was a fungus, actually, that grew in the vials, so that then when they drew up what they were thinking was this sterile cortisone, it had some fungus in it.
Oh.
And over 100 people died from it. It went into the brain and the meninges, and it actually killed them. So we never want that to happen again. Nobody ever wants that. So part of this oversight is worthy, and it's been really great. They're coming down on the pharmacies to say, okay, you've got to follow these particular procedures and protocols to make sure that everything is sterile, that this will never happen again. And because of that, it would be so unlikely for that to ever happen ever again. That these companies, following the strict guidelines, and they're getting checks from the FDA all the time, all these checks and balances. So changing that regulation and that oversight was a good thing, because we don't want that happening again.
Right.
And there were many compounding pharmacies that shut down at that time because it was going to take hundreds of thousands of dollars to revamp their systems and their equipment. And they have to build all these new clean rooms with certain types of ventilation. It ended up being a big deal. So a lot of the compounding pharmacies that didn't have the resources for that, they just shut down. And then the bigger ones that had that could get the backing or had the funding to do that and be compliant with all the new laws, then they're still around.
Right.
No, that makes sense. Yeah, safety audits, you got to have them. So, now, what is the difference between a 503B pharmacy and a manufacturing pharmacy?
Well, so when we're talking about this HR 1959 bill, It's talking specifically about 503A pharmacies, and then you've got 503B pharmacies, and then you've got some separate manufacturing pharmacies. So the 503A and 503B are both compounding pharmacies. The 503A are the ones that are going to be affected by this bill, and the others to date are not. And these 503A pharmacies are the ones that we have in our local areas. There are some that will ship across state lines, but mostly they're the pharmacies close to you that are making your doses in very small batches or just single batches. And they have to have a patient-specific name associated with it. So I put in a prescription for Jane Doe, and I send it to the compounding pharmacy. They mix it up, and then they dispense it to her. So that's our 503A pharmacy, compounding pharmacy. Then we have 503B compounding pharmacy, and they make big batches that are sent to patients and doctors across the country. They don't have to be patient specific. You can use it on anyone that comes into the office, or if you were to, send a prescription into them, they could send it to the patient.
Right.
And they do more manufacturing in that 503B, even though they have usually a compounding aspect to that and then a manufacturing aspect to that. And the manufacturing, so where that gets easier to explain is that the manufactured compound or drug is one that has a specific got a recipe, and the recipe can have the drug with the binders, the fillers, the additives in it. It's the exact same from batch to batch to batch. And so that's really more what we're talking about when we're talking about the manufacturing part of a pharmacy.
Right.
So really the 503A is very patient-specific, small batches. The 503B is a large-scale facility. They manufacture in bulk, and usually it's more for office use only rather than sending it directly to the patient.
Right. Now, are they going to allow Western medical practitioners to administer compound medication and remove it from naturopaths, or is the option being removed from all medical practitioners?
This is going to affect all medical practitioners. So one of the examples I gave already was about the compounded cortisone, which naturopaths don't really use. We like taking inflammation down through diet and lifestyle and maybe, some herbs and supplements. We don't necessarily, and then this cannot apply to all, but we don't necessarily do a lot of cortisone injections like your orthopedic doctor would. So a lot of practitioners are already using compounded medications, and the laws that are being enacted now are going to affect everybody across the board.
Mm.
I will mention, it can differ from state to state, because you do have this, the FDA and the USP that's governing it on a federal level, but the laws still can vary from your state pharmacy board from state to state.
Now, what is the difference, and we kind of covered this earlier, but what is the difference between a compound drug versus a manufactured drug?
So, the things I've mentioned so far, and there's more to this story, but that you can get specific dosing, you can get specific additives, binders, and fillers, so you can put in there whatever you want. Of course, now it's only what's approved. But you can change the recipe. It can change from batch to batch, from patient to patient. So say I want say I have two females and I want somebody to be on 25 milligrams of progesterone and I want the other one to be on 75 milligrams of progesterone. I can send that to the compounding pharmacy, but there is not a manufactured drug that makes either of those doses. So that's the main difference. Now, the other difference, and this has come a little more into play over the last few years, is that oftentimes the drug can be, the manufactured drug is more expensive than what you can get compounded. Mm-hmm. So I've been talking about hormones a little bit. I'll talk about testosterone now.
Okay.
Testosterone manufactured is called androgel. Now, androgel, I looked it up before, kind of as I was preparing for this podcast, is that I looked up androgel, and right now the cost for a 1% 50 ml of androgel is $1,870. Now, it's not very likely that your insurance wants to pay for that. You know, right. How much do you need testosterone? If your testosterone's low, so what if you're a little tired and you're a little weak and you have low libido? You know, so what?
They're not paying attention to quality of life, right?
No. You're not going to die, so we're not going to pay for androgel, which is very, very common. And so instead of doing that, instead of me prescribing androgel, I will prescribe a compounded testosterone. You can do compounding in a cream, injections, in patches, in troches. But the compounded is going to run you $40, $50 for a month supply rather than $1,870.
Right.
So the flip side of that is, so say I wanted to prescribe somebody some thyroid hormone, and I want them to do the combination thyroid that's got some T4 and T3 in it. Typically, I would prescribe maybe an Armour thyroid or a Nature-Throid. Those are manufactured drugs. They have very set guidelines of how much T4 and how much T3 are in them. And for all my patients who are insured, their insurance pays for it. I mean, it's not very expensive either. It's maybe $32 for a month's supply. And then their insurance covers it and they pay $5.
Gotcha.
If they didn't do well on that particular dose and I wanted to compound thyroid hormone and use a different ratio of the T4 and T3, I could send that to a compounding pharmacy, but your insurance does not pay for compounded medications. So they wouldn't pay for it and you'd end up paying $30 to $40 a month.
Right.
So there's, sometimes with that insurance piece, there's a benefit, and sometimes there's not, as far as if you're going to compound something.
Right, that makes sense. Now, what does office use compound mean?
Office use is something that I order into the office and I use on a patient while they are here. So my example of using the B12, doing a B12 injection, I would order in, like right now, I can order in my compounded methylcobalamin, and I can order that in, but I have to order it in for a specific patient. So I have Jane Doe. I do some lab testing. I see she's very low in vitamin B12, and I say, I'd like you to come in and get some injections. Mm-hmm. I can order that compounded methylcobalamin in because right now there's not a manufactured version of it. So I'd have to order it in compounded. So I order it in. It is patient specific, so it's only in her name, but can only be used in the office. So she comes in, I take out my vial of B12, I fill up a syringe, I give her an injection. That's for office use only. The other thing, cortisone injections, that would be, the doctor would order in a vial of cortisone, prepare an injection and inject it into the patient in office. Lidocaine, if you're, you go to the dermatologist and you're having something removed, they're going to inject a little lidocaine into that.
Right.
That's in office use.
Okay. Now how is this restrictive?
Well, right now, the restrictions in the HR 1956 is that. So for instance, this will take me back to that categories 1, 2, and 3.
Right.
Is that the category 3 compounds that they said, we're not even going to look at them. So right now, because it's not fully passed and they're still doing some revisions, potentially pharmacies could have this. But so on this list is Lactobacillus acidophilus. And most people know about that. It's a probiotic. It's a good bacteria that lives in our intestine, and it's on the shelf. You've got all these supplements that have Lactobacillus acidophilus in it. And so I had a patient very, very sick, very, very sensitive. She couldn't even do her thyroid medication in a rice powder, which is usually very well tolerated. So we put it in some acidophilus powder, and she did just fine. She was like, I can finally take some thyroid hormones.
Yeah.
Well, acidophilus is now on the category 3. So, I mean, it was, the FDA just said, we're not even going to look at it. You just can't compound with it. And so that restriction, hurts that particular patient. And so there could be that kind of thing across the board of what we can and can't use. Other things that were category 3 that they said, it's not even worthy of a hearing. So whether that means it didn't have a monograph, that could be possible. They would say it's not worthy if there was already a drug that they felt like addressed the problem, and then we don't need it. But they've got magnesium on the list. They've got copper on the list. They've got zinc on the list. So our compounding pharmacies can't compound with any of those things. And I very oftentimes would have a compounding pharmacy make up a topical salve for warts, other kinds of lesions that you'd put some zinc and some vitamin A in and maybe a little essential oil. And now we can't do that.
Wow.
It was very, very helpful to do that. And even some of the supplement companies who were making some suppositories for certain types of infection or other things like that, they've all stopped making suppositories because of this bill. So it's really in that quality of care that's been restricted, that we don't have access to some long validated, and maybe not necessarily research, but it's been used for centuries very successfully and safely, but they just took it off, just saying, we're not even going to look at that. So What we're trying to do is we really want them to look at this more on a case-by-case basis. What is the harm versus the safety, or that benefit versus risk in allowing compounders to use these substances?
Well, and you really would have liked at least for them to be reviewed. Yeah. So what happens if we leave 503 as it is today?
Well, it's not completely said and done right now. If it were to just be, in writing, all the T's crossed and all of that, then we would be very limited and restricted in what we could use for our compounding in those 503A pharmacies. So like the acidophilus, you want the doctor is always assessing that benefit versus the risk scenario. But you want to have the option of, if this compound or substance is safe for this patient, then we want to have access to that. So one of the things that's in category 1 awaiting a hearing is tetrathiomolybdenate. It's TM for short. I'll just call it TM. Tetrathiomolybdenate is used to decrease copper levels in our bodies. It chelates out that copper. So there are some people who are born with that their genetics do not get rid of copper, and they can have very severe consequences from that, liver failure being at the top of that list. And so that is awaiting a hearing to see if we can still use it. And right now there's not a manufactured drug for it, so it has to be compounded. The other thing we use it for is in cancer care. There is enough research to support that in cancer care, that copper will help promote tumor growth. So in my patients, especially who have breast cancer and ovarian cancer, those estrogen sensitive cancers, I test everybody for copper. And if it's above a certain number, their copper, then I want to get it out of their body, because I think and know that it's going to make their tumor progression worse unless I get the copper levels down. So this TM is not completely safe. If you lower the copper too low, you can get a certain type of anemia. You need copper for your joint health. You need copper. It's in one of our antioxidant systems. It helps our connective tissue. So you need a certain amount of copper, and if it were to go too low, it could be dangerous. But at the same time, it can be very helpful. So it's always assessing that benefit versus the risk. And I want that to be available for my patients who have copper overload syndromes and who have these cancers that seem to be particularly sensitive to having high copper. And so as this goes to hearing, and they're assessing this risk versus the benefit, and they decide, you know what, the risk is greater than the benefit, we're not going to do it. Is it because they don't trust the doctor's knowledge in how to administer that and monitor that to make sure that the levels aren't getting too low? I certainly hope not. I certainly hope that the doctors who would be using that would know how to use it, what to watch for. But that could go with any other manufactured drug too.
Right.
It doesn't have to be just a compounding. You look at Tylenol. You've got, definitely there's a benefit to it. You have a headache, you've got back pain, you take some Tylenol, you feel better. Huge benefit for people. People take it every day. But some people take too much of it. It causes liver damage, liver failure, death. People use it to commit suicide. People die from it every day. But does the FDA take that off the shelves? No, you can just buy it over the counter. So this benefit versus risk, I'm always looking at that. I do that with, just about anything I do, is what is the benefit versus the risk, and is it, in this case, I think this TM is absolutely worth having and being able to compound. Right now, you can't find a pharmacy in the United States that will even compound it, even though as of now it's not illegal to do that. But it can be an expensive medication, so they don't want to get in a kilo of this TM and then not be able to sell it.
Right.
You can get it in Canada, you can get it in Europe, but not in the United States.
Gotcha. Now, many patients who suffer from inflammatory diseases have curcumin and turmeric help with their symptoms. Now, it appears that curcumin is an option being removed. Is that correct? And if so, what effects does this have on these patients?
Well, so what happened with that, and you actually pronounce it curcumin.
Curcumin?
Oh, curcumin. Well, yeah.
No, good call.
So with the curcumin, what happened is that it has been used in Japan for a very long time in an IV form. Mm-hmm. And we started using it in the United States for chronic infections, like it works well for Epstein-Barr particularly. And we also use it in cancer, or did use it when it was available, in cancer care. So it was one of those that was looked at. There was one case in California, one case out of thousands and thousands and thousands of IVs that had been used, where a woman had an anaphylactic reaction to the curcumin IV. The epinephrine that was dosed didn't work, and she died from that. So, I mean, definite risk. so then do you do more testing to say who is at risk? I mean, that things like that happen with iron all the time, for instance, iron infusions, but they don't pull iron off the shelf. You just have to be more careful. And once you know that, certain types of people are going to be more prone to having an anaphylactic reaction to this, so we need to do a test dose or something like that, which is what they do with iron infusions because they so often cause these anaphylactic reactions. But since that happened, you couldn't find a compounding pharmacy to make that curcumin IV in the United States for anything. Mm-hmm. Who knows where we're in this very touchy area and time of passing this HR 1959 and having compounding pharmacies so strictly regulated and watched that nobody wants to compound it anymore. You can go to Canada and get it. You can go to Europe and get it. Probably Mexico. I think they're still using it in Mexico, but not in the United States. And so historically, curcumin has been very safe. There's definitely some research done that it's safe up to a dose of 12 grams a day over the course of 3 months. You know, another study that showed it in combination with a chemotherapy drug, it was well tolerated up to 8 grams a day. And that was for some pancreatic cancer patients.
Right.
And so the safety profile is strong. Like, it was helpful. It was getting people better using it either with chemotherapy or when chemotherapy doesn't work. But what they're saying now is that we have chemo drugs. We don't need curcumin. If it's going to act like a chemo drug, we don't need it. So they just completely dismissed it and said, we're not even going to look at curcumin. We're just not going to let you use it. So, you know, right now it's definitely not on it's completely illegal to compound it list, but it might as well be because nobody's going to compound it.
Oh, wow.
So there were some other things. Artesunate. Artesunate historically was a compounded IV product that was used for malaria for a long, long time. Artesunate is made from a compound called artemisinin, and that comes from a plant called Artemisia. So, I mean, it all comes from plants, and that's why naturopathic doctors are so into that. We really like these plants. So we're looking at artesunate and what it does, and started using it and researching it in cancer therapies. And the mechanism of artesunate in a cancer therapy is really well designed. That cancer cells, they have a tendency to hoard and take in a lot of iron because they're trying to make all this oxygen supply in these new blood vessels so that the tumor can grow and grow and grow and spread and move. So what artesunate did is it would control that part of the cancer tumor being able to incorporate iron into it. And that iron that then damages more DNA. And I mean, we know that artesunate, through research, we know that it's been helpful for cancer. And then you've got all this, you know, you can look at these doctors who have been using that for years and say, yes, my patients that use this compound as an IV have been helped immensely. Well, now they've pulled that, won't let the compounders make it. And so we can't use it as an IV anymore. And so that not only includes the doctors that were using it as an adjuvant cancer therapy, but also the doctors who want to use it for malaria. So now nobody uses it. Nobody can get it.
Oh, wow.
You can take Artemisia and artemisinin orally as a supplement. That's still readily available. But because things like the artemisinin and things like the curcumin that we were just talking about are really hard to absorb through the gastrointestinal tract, doing it by IV just made a world of difference. You got so much more benefit from doing that. And so, you know, even even thinking about this for these inflammatory diseases like cancer, infections like malaria, people are suffering because we can't get that. And the safety profile on artesunate is good. I mean, I am not aware, it doesn't mean there aren't any, but I am not aware of any cases where people have died from it. I will say that, I mean, there are some things that you really have to weigh the benefit versus the risk.
Right.
And so I still, even with artesunate, would definitely be doing that.
That makes sense. Now, for those who want to get involved, what can they do?
Well, the main thing would be contacting your representative in your state. There may be some in your state that are actually co-sponsors of this bill. There's quite a number of both Democrats and Republicans, so it's not just one or the other as far as looking at the politics of this. But you've got, a number of co-sponsors on this bill. And so what you can do is, I wonder if there's a direct link. The link that you would go to find your representative is www.govtrack.us/Congress/members. And that's how you find your representatives. And you can contact them and just write a brief message about your support for the HR 1959 and just state why patient access to safe compounded medications is critical. This is going to be especially good if you or a family member have been helped by compounded medications. You could say what you've been taking, why you've been taking it. You could talk about why you couldn't take a manufactured drug, or why the restriction in this bill would harm your health. If you know any healthcare practitioners in your state, letting them know, because right now they don't have a scheduled date for the hearings for the rest of those 20 compounds. And what we would really like to do is bring back some of those that are in the category 3 and have them actually have hearings on that.
Right. And so that would be govtrack.us/Congress/members, and we'll add the link in the description below as well.
That's great. Thank you.
Yeah, no problem. Well, thank you so much for talking with us today, Dr. Brumley. This was an enlightening experience, and we're all excited here at Trial Site News to see how this continues to develop. And for those of you in the audience interested in learning more about Dr. Brumley's practice, you can reach her at aspireim.com, and links will be provided in the description below. And you can also find Trial Site News on Instagram, Twitter, Facebook, and YouTube. And the links will be in the description below. So thank you for joining us, Dr. Brumley. It's been a pleasure.
Thank you so much. It's been a pleasure for me too.
All right. Well, you have a great rest of your day. All right. And I am cutting the recording.